let's go ahead and get started, and I will turn on the recorder so that those of us who are not here will get a chance to listen. How is everyone? I hope you are hanging in there. I know many of you have started your practicum, and some of you are still waiting. Dr. Smith and Ms. Herbert are working diligently on all of the contracts. They are in those final stages, either between the facility or at TSU. So we are hopeful that we will finish up the very ends of those this week. We did start some of you early this week. Technically, our practical doesn't really start until next week, usually, giving us a week to sort of get things organized and classes underway. But we knew that some of you had some pressing things that were happening in your lives this summer, and some of your supervisors indeed had other obligations. So you will find that during the summer you may be on somewhat different schedules depending on what the SOPs at your facilities are doing in terms of their own vacations or other things that are happening for them. I am going to try to get us started tonight. As you know, summer classes are long. They are technically 4 hours long. I'm hoping that we won't be here for 4 hours, but in order to get all the material in that we are obligated to cover, we are going to be mostly having class for the full time. I will always archive the lectures, so those of you who are either late getting to class because you are traveling to and from a site or have some other issue, you can always go back and listen to the archives. Again, I hope that everyone's practicum placements that have started are starting off well. You'll be with Dr. Smith tomorrow night, and she will give you some more guidance and direction and talk about those issues. If you have other questions, you do have Ms. Herbert's contact information, and she is still monitoring those contracts, but at this point they are all moving through the TSU senior administrative channels. I do want to make sure that you know that I did put up in the TSU, My Courses section, this basic information about this course, the syllabus, the descriptions of each of the projects, and the PowerPoints that we're talking about tonight. Those also are available to you in eLearn. Thanks, Sarah. That's going to happen to us often, that someone is still at their medical site. Remember, you can always use the dial-in, and oftentimes in the summer, because people are late in the afternoon, early evening before leaving a medical site, oftentimes they will dial in at least for the first part of the class. So be safe, but you perhaps, if you do have a long drive, can dial in and listen through your mobile device, and then go back and look at the PowerPoint if you need to, because it will be available to you in the archive recordings. I do want to tell you how much I thank you for those of you who have submitted your needs assessment. The needs assessment gave me a lot of information about your prior experiences with people with hearing loss, either students you've had. Many of you shared coworkers or family members that have hearing loss, and all of those experiences really, I think, will stand you in good stead in this class, and I do urge you to share where you are comfortable, specific experiences that you have had with individuals with hearing loss. So I appreciate that information. I did remind each of you, or most of you, when you made a comment about having worked with a student who had a hearing loss, having babysat for a child with a hearing loss, having a family member, having a coworker. If you choose, you may use those individuals whom you already know for your capstone case study in this class. Obviously, only with their permission, and only if you can get, if they will release to you, a copy of their most recent audiogram. Because part of that assignment, which we're going to talk about in just a minute, involves using their actual audiogram to complete part of what you need to do. So it does need to be someone that you do have access to in terms of having their audiogram and being able to talk with the individual and or significant others in their environment. A parent, if it's a child, an adult child, if it's a geriatric client, so that you can develop background information and case history information. Many of you will choose to do your capstone case study for this course on someone who you saw perhaps in a school system in your previous school-based practicum, or an adult in your medical placements this summer. Again, I want to caution you that it does need to be an individual that you have access to background information and an audiogram. It is not an individual that you will actually be treating. So this is a paper, a project, where you discuss the person's needs, and we're going to talk about that, and you discuss appropriate interventions. But it's not one where you actually have to implement the intervention. So it does not need to be someone that you are currently treating. So as you start thinking about who you might choose, kind of keep some of those things in mind. You will have each week in this class chapter questions. Thank you all. Many of you have submitted those. I think I scored all of the ones that have been submitted by, say, noon or 2 o'clock this afternoon. There's some of you, I'm sure, who are doing those tonight. They are due typically each week before class starts on Wednesday. And the purpose of that is I do want you to read the textbook chapters before we talk about them, so that the information that we talk about, we can delve further into the topic. We can talk about other resources rather than just looking at the textbook page by page, line by line. The other thing about the chapter questions is they form an excellent study guide for your midterm exam and your final exam, which are online in eLearn. And I'll give you a study guide. In fact, the study guides are actually posted in eLearn under the content section already. But each set of chapter questions is important information to study. It's important to study for the exams in this class. It's important to study them for your comprehensive examination, which Dr. Smith will be talking with you more about. And it's important in general as you study for the practice exam. So I urge you to complete those chapter question assignments by Wednesday at 5:30 before we begin class. So that when you come to class and we talk about chapter 15, or we're talking about chapter 5, or we're talking about chapter 10, you've already got that basic information in hand. So again, we can go further. So today there was a set of chapter questions from chapter 1 and chapter 15. That's really the only time we're going to do some real skipping around in our text. And I wanted us to cover a little bit of the information from chapter 15, because it does talk about communication modalities, and we need to have that basic information as part of our foundation for talking about our communication modalities project. So please do submit those chapter questions. Next week, your chapter questions will be the chapter questions from chapters 2 and 3 as we begin to talk about assessing speech and hearing, particularly speech recognition, and we talk about amplification devices of various types. Some weeks in this class, you will also have a discussion question, and this is one of those weeks. The discussion question is not due until next week, June the 13th at midnight. And this is an individual assignment, so you can certainly go do it right now, or not right now, but you can do it tonight or tomorrow. Remember, you are to post your response, and then you are to reply to any 2 members of the class. So you don't have to wait for one of your team members to post. You post yourself and you reply to 2 members of the class. There's a scoring rubric posted in eLearn that talks about what those discussions need to look like to obtain the entire 10 points. The minimum requirement is that you post and you reply to 2 others, that your post be responsive to the questions asked, that it cite or reference either the text, other articles, professional information about the question. Do make sure that you complete those discussion questions. I'll try to remind you each week when one is due. So again, you want to make sure that you are providing high quality information, that you demonstrate critical thinking, that you refer to textbook or other reliable evidence-based practice sources, and that your language is appropriately consistent in both the vocabulary and the writing style. So please do look at the discussion scoring rubric if you have questions for the chapter. Questions that you submit to the eLearn drop boxes, they are scored on the basis of timeliness, completeness, and correctness. So they need to be submitted on time by the due date listed in the drop box. They need to be complete in the sense that you wrote out the text of the question and the text of the correct answer written out. I'm going to tell you a funny story about that in just a minute. And if you get the correct answer, they are all answered in the chapter material. They are intended as self-assessments. And again, they form sort of a basis of a study guide for you for your midterm and final exams. The funny little story I want to tell you is that I did this several years ago when I taught this class, and one student came up to me after the exam and she said, "I don't think I did very well. But everyone tells me that these questions on this exam came from the chapter questions." And I said, "Yes, we went over that several times." And then she said, "But when I did my chapter questions, I wrote down number 2C. And I thought I was supposed to study number 2C. And I honestly just looked at her and I thought, my goodness, you are in graduate school and you thought that would be the way a test would be written? I just went, you're kidding me. I tried not to say that. But so when I ask you to write out the stem of the question and the correct answer, I'm hoping that helps you learn the material in some other way other than number 2 is C. So that's the reason I'm asking you to do this. Actually, students say it turns out to be very helpful, that they actually have a great study guide already ready to go just by using their Dropbox submissions. Let's look at the syllabus and sort of go through it step by step. If you look at the TSU graduate catalog and the description of this course, this is what it says, that it is about principles and methods of electroacoustic instrumentation, meaning hearing aids, cochlear implants, bone-anchored hearing aids, assistive listening devices of various kinds, involved in oral habilitation and rehabilitation of hearing impaired individuals. That it includes a basic introduction to both oral approaches to habilitation for people with hearing loss and manual communication. We do not have time, unfortunately, and I really regret that, in your TSU Communication Sciences and Disorders program of study to include a course in manual communication, either American Sign Language, ASL, or one of the manually coded systems of English like C-Signs, Signing Exact English. In many communication sciences and disorders programs, ASL will actually be a major or a minor within the department, and students oftentimes come into their master's degree with, if not proficiency in manual communication, at least some basic introduction. So again, I regret that in this short summer course and the way this curriculum at TSU is structured that you don't have that chance. I do want to encourage you to consider that as one of the tools in your toolkit that you might want to add. I know some of you have said, I have some basic familiarity. I did some sign language work in my undergraduate program, and that is really a very good thing. That is a very important thing. But in essence, what this course in our TSU curriculum is really about is to help us think about the role of speech-language pathologists in working with hearing-impaired individuals. We are not audiologists. I am, but I'm not in this course. I'm a speech pathologist. But as speech pathologist, ASHA has been very clear that hearing-impaired persons and serving and meeting the needs of hearing-impaired persons is in our SOP scope of practice. That does not mean that we fit hearing aids. It does not mean that we do diagnostic audiology testing. We don't. That's the role of the audiologist. But from a very practical position, there are many more SLPs than there are audiologists. And SLPs tend to be located in the facilities where people with hearing loss are being served, often for other reasons. Many of you are getting ready to go into medical placements this summer. Very, very few of the medical placements you go into will have an audiologist on staff, unless it's an academic medical center with an ENT department. Many of you will be in skilled nursing facilities, in regional hospitals, in long-term care facilities, and you and your mentors and supervisors as SOPs are the hearing resource persons for those patients. You may be seeing the patient for a swallowing disorder, and that's the CPT code you're going to use. That's how your facility is going to get reimbursed. You may be seeing that client for cognitive or language training, and that's the nature of the treatment. But the person may have a hearing loss. And as an SOP, ASHA would say to us, you can't ignore that hearing loss. And in fact, I put up in eLearn a couple of articles from the ASHA Leader in 2015, and they were directed to SLPs and what is their responsibility for working with patients with hearing loss, particularly those in skilled nursing facilities, where oftentimes those residents don't receive appropriate screening for hearing or treatment. So I want you to go look at the article by Dowd, D-O-W. I put it up in eLearn as an attachment. It's from 2015, and it was from the ASHA Leader. And it's simply a very short little article about when hearing loss goes unnoticed, hearing difficulties can easily be missed in skilled nursing facilities, which means residents receive no or unnecessary treatment. And it talks about what we as SLPs can do with simple screening, not even audiometric screening. simple word screening, to begin to call the attention of the staff to the fact that some of those residents presenting problems may in fact be the result of hearing loss and maybe not dementia, maybe not aphasia, or maybe it's a both and. I think it's a really interesting article that makes me think about what my responsibility is as an SOP, and how I can better meet the needs of those geriatric clients in skilled nursing facilities. Because if you just look sort of at the data that's out there, the data would suggest that 80% of the skilled nursing facility residents have some degree of hearing loss. And oftentimes it's not noted in the medical chart. Oftentimes the residents didn't get to the skilled nursing facility with amplification, even if they had been fitted with a hearing aid prior to admission. But what we see is that residents in skilled nursing facilities have a very high incidence of chronic diseases that are associated with hearing loss: diabetes, hypothyroidism, chronic renal disease, cardiovascular disease, Alzheimer's. And that hearing decline is also commonly linked to medications, pain medications, loop-inducing diuretics, some antibiotics, some cancer chemotherapy. And so as SOPs, we have a responsibility to talk about that with the rest of the staff, to try to pursue hearing screening if that seems indicated, but even before that, to do a brief screen. So again, I want to encourage you, given the placements that you are in this summer, to be thinking about that. I'm not asking you, and I don't want you to approach your supervisor and say, well, we should be treating this person for hearing loss. That's not going to happen, and that's not your role as a student. That patient is going to continue to be served for swallowing, for aphasias, for cognition, just as they normally are. But hearing is a part of the picture, and just taking that into consideration, simple training that we can do with the rest of the staff to talk to them about, maybe Mr. Jones appears confused, or maybe he answered inappropriately because he really didn't hear you. Are you sure you're facing him? Are you sure you're giving him other cues? So simply information presented to the other people on the team about how to communicate effectively with a person with a significant hearing loss is something that we need to try. So again, audiologists are trained. You are getting trained right now and are going to be well trained in providing audiological rehabilitation. And actually those services are reimbursable through Medicare Part B. But it's less about that, and it's more about, it is in your scope of practice, and it is one of your responsibilities as an SOP to individuals with hearing loss and other communication disorders that we try to advocate for them, that we train the rest of the staff. So take a look at that article by Catherine Dowd, and we'll talk more about it as we go along. But again, I want to impress upon you that one of the purposes of this course is to help you understand what your role is, what's in your scope of practice, what ASHA says to us as SLPs about the importance of understanding the etiology, the characteristics and consequences of hearing loss in the broadest sense. So we're going to be talking about not only communication consequences, but psychosocial skills, educational and vocational implications. And we're going to talk a lot about our role as SLPs as a member of this team. If there ever is an area of practice where interprofessional practice, IPP, is critical, it is with this population. We, as SLPs, are simply one member of the oral rehabilitation team. But we are a really critical member because there are not enough audiologists to go around, certainly not enough audiologists in a school setting, in long-term care settings, in skilled nursing facilities, and it's the SLP who is the boots on the ground. The SLP is the person who's there, who's actually treating these individuals for other aspects of communication disorders. So we can implement appropriate techniques, communication strategies training, monitoring hearing aids, cochlear implants, bone-anchored hearing aids, various kinds of assistive listening devices, and hearing-assisted technologies. We can provide counseling and guidance for the individuals, but also for their family members and the educators with whom they come in contact in the school setting, and the other healthcare providers with whom they interact in residential facilities. So we're going to spend some time focusing on that. This class is about meeting those requisite knowledge and skills for the Certificate of Clinical Competence. And these are the ones that specifically stand out, that we are going to learn about the acoustic basis of communication disorders. We're going to learn about the nature of hearing disorders across the lifespan. And we're going to focus on the developmental characteristics and the linguistic characteristics of children who are either born with hearing loss or acquire hearing loss early in the language learning process. We're going to talk about the psychosocial, educational, and cultural and vocational implications. We're going to look specifically at culturally and linguistically diverse populations within the broader group of individuals with hearing loss. And we're going to spend some time talking about the deaf, capital D-E-A-F community. Certainly here in Middle Tennessee and in various parts of the country, there are large groups of individuals who are deaf, with a capital D, meaning they use American Sign Language. They see themselves as a distinctive subgroup of individuals. And so we want to be knowledgeable about that population. We'll talk a lot about the fact that there are many, many different approaches to addressing the communication needs of persons with hearing loss. It depends certainly on the degree of hearing loss, their use of assistive devices and technologies, but there is also a choice issue. Families who are deaf and have deaf children often feel very strongly that they want their children, both those who have hearing loss and those children who do not have hearing loss, to learn American Sign Language as their first language. They want that to be their primary means of communication. And Asha is very clear that that is a cultural choice that that family makes, and that ethically we as audiologists and as speech language pathologists are to respect the family's choice. Might not be what you would choose for your child, but if a family chooses a manual communication option as their first choice for their child, we have to be respectful of that family choice, just as we're respectful of other cultural choices that families make. So we'll do some talking about that. And where does that put us as SLPs? We are going to talk a good bit about the various kinds of electroacoustical instruments that can assist people with hearing loss. We're going to talk about hearing aids, cochlear implants, frequency modulated systems, other assistive devices, bone-anchored hearing aids. And we're going to learn how to do what Asha says is in our scope of practice, which is to functionally monitor those instruments as part of our service to persons with hearing loss. We don't fit them, we don't diagnose, we don't recommend them, but we can monitor whether they're working. And unfortunately, multiple studies replicated across the United States in multiple sites over many years indicate that if you simply look at a population in a skilled nursing facility, a population in the school system of individuals who have been fit with electroacoustical devices, meaning hearing aids, FMs, bone-anchored hearing aids, cochlear implants, about half of those devices on a given day are malfunctioning. Now that is an astounding statistic to me, because what it means is that half of these children I'm seeing, even though they look like they've got something hanging off of their ears, it's not working. Half of these residents in this skilled nursing facility have a device that's not working. And the frightening thing about that is that we assume that it is working. And so we assume that the individual is getting the benefit of that improved audibility, when in fact they're not. So clearly the answer is that we have to do a better job of monitoring those devices. And most of those many research studies suggest that the majority of problems is a dead battery. The battery put in backwards, wax in the tubing, dirt over the screen of the microphone. Simple little things that are easily fixed by parents, healthcare providers, SLPs, teachers. So sometimes the fix is really simple. And again, we as SLPs need to be mindful of that, need to make sure that the residents in the facility that we work in, the children in the school that we work in, have a daily monitoring program that someone, sometimes it's the child themselves, the resident themselves, is actually monitoring their hearing aid. Is it working? And we're going to talk about how to do that. We also are going to spend some time in this class talking about looking at how do we design. That's fine, Amanda. I've recorded everything so that if anyone is late because they're somewhere else, you can go back and listen to the archive. One of the things that you are going to do in this class is that you're going to design, as part of this capstone case study, a collaborative interprofessional practice plan for a single patient. Again, can be a child, an infant, a preschooler or a school-age child, a young adult, or a senior, a geriatric patient. And we're going to talk about how to put in place a plan. You don't have to implement it, but a plan. How would you assess this person? How would you counsel and guide this person? What specific types of intervention would be appropriate? So again, you get to choose. Is it going to be an older adult, or is it going to be a child? And then that case study that you do becomes one of your e-portfolio artifacts. The other e-portfolio artifact is this thing called the Communications Modalities Project, which we talked a little bit about in the spring, just as a heads up. And I'm going to talk more in detail about that. For those of you who are seeking some sort of educational credential in Tennessee or in another state, this class would meet the requirements of the educational licensure, that you understand the role of the SOP in working with individuals with hearing loss. You all have seen these before because these goals and objectives were the goals and objectives in your schools class. We just didn't focus as intensively on hearing impaired children and we simply talked about them in the context of all of the different kinds of communication disorders that we see. So your textbook is the Nancy Ty Murray textbook. I'm going to be teaching out of the 3rd edition, which is less expensive to you. There is a 2005 4th edition. I actually have it and like it very much, but it is not substantially different from the 3rd edition. And I've got lots of other resources from ASHA, from the American Academy of Audiology, and the Oral Rehabilitation Association that we're going to be using. So we are not going to be missing anything. Again, I gave you a whole bunch of websites. Those websites, in addition to the ones listed in your text, should be very helpful to you as you put together this communication modalities project. So let me just sort of briefly tell you about these. Oral Deaf Ed is an organization that was actually funded by a trust fund from the Oberkotter Foundation, and they spent millions, literally, millions and millions of dollars putting out educational literature for parents and teachers and physicians about oral deaf education. What is hearing loss? Why is early intervention important? What can children do if they are early identified? The A.G. Bell organization, A.G. Bell, named for Alexander Graham Bell, the inventor of the telephone, is one of the oldest organizations in the country for parents and professionals who work with children with significant hearing loss. And it too has a very rich website with lots of local chapters of that organization to help and support families of children with hearing loss. NAD is the National Association of the Deaf, a very old organization of individuals who are members of the capital D deaf community. So this is deaf individuals themselves as their own advocates, and professionals and other educators who support them and provide resources. Go Here is another nonprofit organization that is really committed to helping parents understand what their options are. Gallaudet is the National College for Hearing Impaired Individuals, Gallaudet University. It's in Washington, D.C., and it is the source of the National Deaf Education Center and the National Technical Assistance Center. So it has a huge research database and curriculum database on everything about hearing loss. It has a center called the Laurent Clerc Center, and it has, again, a very rich set of materials. And they're all, again, at Gallaudet. So if you're thinking about, okay, where am I going to go to get information, you want to make sure that you are looking at reputable resources, reliable resources. And I put up several different others. Cued Speech is a system for adding more information to the visual and auditory signal. It's not a language, it's supplemental support to support individuals with hearing loss who have difficulty auditorily and visually discriminating different phonemes. But it is a system that is used in some school districts across the country. So here's some useful websites as you begin to start exploring, putting together your communication modalities project. So here are the course requirements: online attendance, group participation in the group discussions. There are 7 discussions spaced throughout the course. Chapter question assessments, there are 15 of those. The capstone case project, which we were discussing. The midterm proficiency exam, the final proficiency exam, and the communication modalities project. Again, the TSU grading scale that you are all by now very familiar with. I do want to remind you that when you put together your communication modalities projects and your case study paper, that you are mindful of references and making sure you are appropriately citing all of your references using APA format. So again, class attendance, come to class, or listen to the archives if for some reason you can't. Submit the end of chapter self-assessment multiple choice questions written out in full, and participate in the class discussions and the discussion forums. Your capstone case study I provided in eLearn and in the My TSU, My Courses section, actual scoring rubrics for this project. I put up a points-based scoring rubric, and I put up the case study sort of scoring rubric. You are developing a detailed case study of a child or an adult, and you get to pick. This is your chance to say, you know, I'm more interested in children than adults, or I'm particularly interested in adults who are working adults, or I'm particularly interested in geriatrics, or I'm particularly interested in young infants and toddlers. So you get to choose whether it's a pediatric case or an adult case. The requirement is that you do have access to the patient's background medical information, educational, vocational history information, and that you have access to an audiogram, because you're going to be interpreting that client's history, audiometric, communicative needs, whatever their amplification status is, so that you can design a comprehensive oral rehabilitation plan for the client based on evidence. So you're going to have a section on background information, the audiogram, any other audiometric testing, any other significant medical information that you have. We're going to take the patient's audiogram and we're going to put it on what we call the familiar sounds audiogram that Dr. Matlock talked to you about, or the count the dots audiogram, so that you have a vehicle for explaining to parents, to teachers, to adult children and older individuals, spouses, what this hearing loss actually means. So we're going to put it on the familiar sounds audiogram, if it's a child, and we'll talk more about that, or the count the dots audiogram, if it's an adult. The reason for using the count the dots audiogram is that most versions of the familiar sounds audiogram look somewhat juvenile. There are pictures of saws and pictures of babies crying and pictures of trees with rustling leaves that are cartoonish for the most part. And while some adults are fine with that, there are a lot of adults who react, if not visibly react. They will tell you later, well, they put all those marks on that silly little picture. And that's not what we want. We want our clients to be able to hear and understand our explanation of what their hearing loss is and why this hearing loss produces for them communication difficulties. And so the count the dots audiogram supplies essentially the same information. It takes 100 dots and it puts them on the speech banana from the familiar sounds audiogram. And it just looks less juvenile. I put up an article about count the dots. We'll talk more about it. But again, the idea is you have to have an audiogram in order to fulfill the responsibilities of this capstone case project. So once you've done that audiometric information, information about background case history, information about what kind of amplification the person has, whether it's hearing aids, cochlear implants, bone-anchored hearing aids, some sorts of assistive listening devices, is whatever is applicable. Then you're going to talk about how would you instruct the family, the teachers, the healthcare providers, the patients themselves to do basic functional checks and monitoring of their devices. One of the things that we press very hard, very early, is to have young children begin to take responsibility for their devices. Now, that does not mean that there isn't an adult close by also monitoring. But we want young children to take responsibility for their hearing loss, responsibility for the fact, is your hearing aid working? What if your battery goes out in the middle of class? It's your responsibility to alert your teacher, your SLP, your parent, that you need help. So we want to make sure that even our younger children are gradually being trained and taking more and more responsibility for the functional checking and monitoring of their devices. And then your capstone case study is going to include counseling issues, informational guidance. We're going to be talking a lot about patient-centered, family-centered practice. And so you will want to be pulling together in this section of your case study the kinds of issues that you think should be addressed, not only with a client, but also with significant others as partners, communication partners of this person. If appropriate, you're going to be talking about speech, language, auditory training, speech reading types of goals. You're not going to implement this project, but you're going to set up goals and objectives. You're also going to be talking about what we call communication strategies treatment. All of these are chapters in your book. So by the time you get to writing this capstone case study, we will have talked about them in detail. You'll be addressing whether this particular client you've chosen is an appropriate candidate for oral or manual communication, again, as needed. And then you're going to spend some time actually writing a section of your plan about collaboration with others in the client's environment. So the audiologist, the family members, the teachers, the coworkers, the healthcare providers, the spouse, the adult children. And then you're going to embed in your project documentation of research evidence for the recommendations that you make, the practices, the approaches, the techniques that you're proposing. Again, they will look very different because your clients will be very different. So some of you will have more meat and discussion about a counseling issue. Some of you will have more meat and discussion about speech and language training if it's a child in the process of learning language. The other major project in this class that is part of your e-portfolio is this communication modalities project. Now, this is a team project, and unless I hear otherwise, I'm going to suggest that we leave our teams from the spring in place. 2 members of the class who were here in the spring are not here this summer, but otherwise, I'm going to suggest that you keep the same teams. If I hear someone who says they don't like it, I'll simply move you to a different team. But this is a team-based project. This is the project that we did talk about a little bit in the spring. It is what TSU determined they would do as part of your curriculum to meet the ASHA requirements of augmentative and alternative communication and communication modalities. Because you do not take a freestanding course in AAC and assistive technologies. This project is being used to meet the ASHA standard 4C related to communication modalities, including oral, manual, augmentative, and alternative techniques and assistive technologies. Those are the words directly out of the standards. I've given you, again, a scoring rubric. I've given you some examples in eLearn of tables of contents. Again, I want this to be helpful for you, so I don't expect each team's communication modalities project to look exactly the same. Some teams may decide that they want to focus specifically on building an electronic resource file focused on children, because you think that that's the first population that you are going to go serve. Others of you may want to focus primarily on adults. I've had people take this class who said, I want to focus on making a resource file where everything is in Spanish. A lot of these materials are in Spanish. Now, that is not true of many other languages, but certainly there has been a real effort by advocates of people with hearing loss to at least provide many of these materials in Spanish. So again, you as a team need to sit down and sort of see, okay, do we want to focus primarily on children, primarily on adults, or some sort of interesting twist on that, like Spanish-speaking individuals? Or do we simply want to put together a generic electronic resource file? I've listed the basic topics that need to be covered here. But again, there's flexibility. For each major topic, you need to provide an evidence-based practice article that supports and provides the evidence for the use of that technology or approach. You need to provide one or more, 1 or 2 or 3 resources, pamphlets, handouts for families, Q&As for families, descriptions of these different systems or resources. And then you need to write a critique, a synopsis, a narrative synopsis. What have we included in our section? What is the research evidence that supports this approach, this technology, this strategy? And how are we going to use these materials? In some cases, it might be something on FM systems, and you might provide a resource from one of the manufacturers of those devices about how to use those devices in the classroom. And so clearly the audience for that is teachers. You might provide another resource that would be a guide for parents. And then, as I say, you want to explain what the resources are, why they are appropriate, how you intend to use them. So I gave you several examples of tables of contents. I don't intend for you to follow them absolutely, but I wanted to give you just some more guidance. I'll be happy to talk with you about that, and I will answer some questions. But it's always got to have an evidence-based practice support. It's always got to have resources, which are the artifacts, the sample materials, the handouts for families, the handouts for healthcare staff, extra questions, and then a critique, a narrative rationale. Why did we include this? What do we intend to do with it? How do we intend to use it? Some of you may want to add additional sections. I've had people do that. Some people have been very interested, for example, in what's called CART, real-time captioning, the kind of alternative to note-taking. And so they've added a whole section on communication access, real-time translation, and captioning systems. So you may add extra sections in addition to the ones that I've listed that need to be there. So again, all of this gets uploaded to eLearn in separate folders for each major heading and table of contents. And again, what I'm going to ask is that if one of your group uploads the majority of the documents, that each member of the team also do that same sort of thing that we did in the spring, the little Word document saying, you know, I participated in this project, I accept responsibility for our group scoring. So let's see. Okay, again, if you need to have accommodations in this class, you need to identify yourself to me early. You do need to seek the assistance of the Office of Disabled Students and have that accommodation information sent to me. I have developed this schedule sort of based on 4 modules as a general guide. We will do our best to stick to this. I did look carefully at when your comps were scheduled. I know many of you intend to return to work, but TSU does not change its schedule to accommodate your work schedule. We have to follow the university schedule unless you and Dr. Smith decide that you're going to do something else, and she tells me I have to do something different. But the university is a 10-week session. So that means that we technically go through the first week in August. Your practical, we're ending early, but the classwork does continue. So here's tonight, and we, in fact, are going to do this. Again, I want you to go look at the Oral Deaf Ed website as sort of an extra thing to look at. We're going to talk about Chapter 1, looking at service delivery models, and we're going to talk about part of Chapter 15 on the characteristics and consequences of hearing loss. Then next week, we're going to talk about assessing hearing and speech perception and amplification. It's Chapters 2 and 3. Then the following week, the third week in June, we're going to talk about auditory training, building auditory skills, and speech reading and speech training. And we're going to visit the websites of some of the computer-assisted technologies that are out there. One in particular called LACE, and we'll also look at one developed just recently by the author of your text, Nancy Ty Murray, called CLEAR. C-L-E-A-R, big, E-A-R is big. But it's an individualized online computer-assisted listening program. Then the last week in June, we're going to talk about communication strategies and how do we assess an individual's communication skills in communication dyads. So what are the real breakdowns and types of problems that individuals with hearing impairment have, above and beyond just fixing their speech sounds or fixing their grammatical structures, as we often do with children with severe hearing loss. What is it that breaks down when an adult experiences an acquired hearing loss? What is it that we see in our geriatric population when they can't follow a conversation? So we're going to talk about how do we look at those communication breakdowns, and even more, what strategies do people with hearing loss try on their own to solve their problem, and which ones of those are effective? Some of them are, and some of them aren't. And then we're going to talk about, so what is our role as SOPs in training individuals to use effective communication strategies when there is a breakdown? What is our role in training partners who are their frequent communication partners in how to be a more effective communicator with a person with a hearing loss? And then we're going to talk about counseling issues. One of the difficult problems often with individuals with hearing loss is that they don't accept their hearing loss, they try to bluff their way through, or they withdraw and become socially isolated. With children, we sometimes see that as they grow more and more in their own self-awareness, that they begin to reject their hearing devices. They don't want to be different from their peers. So we're going to talk about some of those counseling issues. And we're going to use some material from something called the IDA Institute. It's an international consortium of professionals who work with people with hearing loss, academics who teach in this area, manufacturers of various devices, to build a rich set of resources for people, for professionals who are working with people with hearing loss. And they have a lot of counseling tools, simple little counseling tools that we can use to try to help our patients own their hearing loss, accept their hearing loss, and work towards solutions that work for them, rather than our role as the expert SOP or the expert medical doctor or the expert audiologist. coming in to tell the patient, the family, what they should do. How can we help the patient actually participate in that? How can we become truly patient-centered? How can we focus on the patient solving their own problem? With our assistance, absolutely, but a much different approach. And that's actually what we're going to talk about in just a few minutes as we look at Chapter 1 in your textbook. Then we will have a midterm proficiency assessment in e-learning after your comps. I purposely put it a little late in the semester, after your comps. And then we'll move on to considering specifically hearing loss in adults. So sort of the first half, a little bit more than half, of the course is about basic information applicable to children and adults. We'll use examples from both children and adults. And then we'll spend some time talking specifically about hearing loss in adults. I put up one of those articles in eLearn that talked about the research by a man named Frank Lin, L-I-N. Dr. Lin is a physician. He also is a PhD in epidemiology. He is at Johns Hopkins. He is conducting a huge longitudinal research program looking at the interrelationships between hearing loss and dementias. And he, through this long-term study known as the BALSA study, the Baltimore Longitudinal Study on Aging, has developed some really fascinating research that has been widely published in academic medical journals and in the Journal of the American Medical Association. So I'll put that little article up there for you just to get a little taste of that. We'll talk more about it as we go along. But when we get to July the 12th, we'll focus more in depth on the problems of adults. And we will spend some time talking about the special needs of the geriatric population in healthcare sites. So we will spend a good bit of time talking about skilled nursing facilities. And again, what is our role? Your capstone case study is not due until July the 19th. So you've essentially got 6 weeks to pull this together. Then on the 26th, we will focus back in on children, and we will be listening, we will be looking at what to do with children with minimal and mild hearing losses, as well as those with severe and profound hearing losses in young children. We'll talk at the very end of the class about an approach to teaching speech with individual children with hearing loss who have profound hearing loss, severe and profound hearing losses, who are not learning speech and language skills through their hearing aids or their cochlear implants, or at least not learning them normally, and who need a highly specialized speech approach to develop effective, clear speech. So we'll talk about the Ling approach, named for Dr. Daniel Ling, who developed an approach for these youngsters with very severe and profound hearing losses. And then we'll talk about cochlear implants and auditory processing disorders. I know that Dr. Matlock gave you an excellent introduction to auditory processing disorders. We'll try to focus on what Asha says our role is as SLPs in addressing auditory processing disorders, particularly in children, but we'll also talk about auditory processing disorders in adults. And then your communication modalities project is not actually due until August the 3rd. So you have essentially the whole semester to actually do that. And then your final exam will be open for a window of several days at the very end of class. Okay, shall we take a little break for just a minute, let everybody go get something to drink, and then we'll come back and we'll actually start on Chapter 1, Service Models in Oral Rehabilitation, and I'll certainly answer any questions. Nicole, I'm going to defer your question about is it proctored. Dr. Smith and I are having a discussion about that. So let's all go take just a brief break and I will come back and talk with you. Okay, ladies and gentlemen, are we ready to get started again? While we were gone, did any of you come up with any additional questions or anything I can answer about clarifying what's in the syllabus, what the expectations are, what the due dates and timelines are? If you have, if as you start working through these and you have some questions, please don't hesitate to ask, because I certainly don't want you floundering around. You've got a really tight summer with significant practicum, a short time frame, cost to study for. So I want to make sure that you understand exactly what you need to do and you don't expend any unnecessary energy. My experience is that people in this DE class are well able to do this within this time frame. Every year students in our residential program take this class in the semester in which they have comps as well and are able to manage. So it is certainly doable, but I do want to be able to clarify for you any questions or concerns. We're going to begin tonight looking at Chapter 1 in your Nancy Ty Murray text, Foundations of Oral Rehabilitation, Children, Adults, and Their Family Members. And again, I am teaching from the 3rd edition of this text. So Chapter 1 begins literally on page 1. And this Chapter 1 begins to walk us through what is oral rehabilitation, what is hearing health care, what is the World Health Organization model. I hope that some of you, as you worked through your chapter self-assessment questions, when you came to that question about the World Health Organization and went back and looked at figure 1-1 on page, let's see, what page is it? On page 4, you went, oh, I think I've heard of this before, because it is in fact the foundation from which ASHA takes our scope of practice. ASHA is a strong believer in using this World Health Organization model for communication handicaps and thinking about our clients in a much broader context than just, are they ears that don't function, or are they mouths that don't function? I also want to call your attention to another resource that I put up in eLearn by Jean-Pierre Gagné at the University of Montreal, called A Person-Centered Approach to Audiologic Rehabilitation, that combines this World Health Organization International Classification of Functioning into this idea of patient-centered approach. I always think that it's a nice thing, in a way, that this class comes at the very end, and in a way that we are now moving toward getting the bigger picture. A lot of your courses in our TSU curriculum focus very specifically on a disability. How do we assess it? What is it? How do we assess it? How do we treat it? And we go through a whole series of different disorders. And this class is similar in that it's focusing on hearing impairment and what is it and how do we assess it and how do we treat it. But it's also a class where we step back a little bit and we start looking at the person with the hearing loss as a whole person. We start looking at the child with a hearing loss as a whole child. And we begin to think about the impact of hearing loss in its broader context. And we acknowledge, hopefully not for the first time, but we specifically acknowledge that approaches to therapy and intervention with people with hearing loss have to be client-centered. They have to be a problem-solving approach where we're focused on activities and participation rather than the health condition itself, rather than the body structures, the functions. That's important, but in many cases, by the time the patient arrives at our doorstep, our classroom, our therapy room, our skilled nursing facility, there is not a medical cure. There's not a pink pill. This person has a hearing loss. The hearing loss is essentially a permanent condition. And so we begin to approach our assessment and intervention in a little different way. This is not the quick fix where everyone's going to think, oh, wonderful SOP, fix the problem. This problem isn't going to get fixed. People are going to learn, however, to live well with hearing loss. That's really one of the visions of that thing I talked about, the IDA Institute, that international consortium, that interprofessional practice group of folks. Our goal is to have people live well with hearing loss. We are beginning to see hearing loss more and more like other chronic conditions. We talk about people living well with diabetes, living well with hypertension. So it's more about taking into consideration the person, the context in which they live or work or recreate or socialize, and thinking about how can we make it better, and listening to our patients who have a lot to tell us about what really would work for them and what really is the problem, as opposed to our saying, I know it all. I have all these letters behind my name. I have all these degrees. I'm the expert. One of the fundamental principles of oral rehabilitation, and ASHA is beginning to really espouse this more and more, is that we don't have all the answers, and that we have to incorporate our patients as partners in the process. So I put up that ASHA professional development presentation by Dr. Gagne from an ASHA online conference for audiologists because I thought it was an excellent way of helping us match exactly what's in the Nancy Time Murray Chapter 1, looking at this World Health Organization International classifications for functioning, thinking about AR as a process, as a client-centered approach. So I want to encourage you to take a quick look at that. It's a simple PDF. You can scan it very quickly. If we think about what hearing care is, it's been defined by lots of different people in lots of different ways, but it's consistent in its definitions from individuals who are members of ASHA or members of the American Academy of Audiology, in that we are talking about care provided to individuals who are seeking relief from the effects of permanent hearing loss. That is a hearing loss that is not medically or surgically correctable. So we're not talking about fluid in the ear. We're not talking about even some middle ear diseases where we can do reconstructive surgery. We're talking about a hearing loss that is irreversible. And so we must consider the relationships that those of us who are healthcare professionals need to build and maintain with the individual with hearing impairment and their family. That the intervention, as Nancy Ty Murray defines it in Chapter 1 in your textbook, we have to be thinking about it on page 2 as intervention aimed at minimizing and alleviating the communication difficulties associated with hearing loss. ASHA actually defines this AR as an ecological interactive process that facilitates one's ability to minimize or prevent the limitations and restrictions that auditory dysfunction can impose. So again, we are talking about from page 4 and the World Health Organization model. We're thinking about communication activity limitations, participation restrictions that this hearing loss can impose. And ASHA goes on to say that it can impose difficulties in well-being and communication, including interpersonal, psychosocial, educational, and vocational functioning. Now, that doesn't mean to imply that everyone with a hearing loss is going to have negative consequences in all of these areas. But if we look at the research, both in this country and internationally, over a long period of time, across individuals who use widely different technologies and have been exposed to widely differing interventions and educational approaches, there is at least significant evidence that many individuals with severe hearing loss do experience at some periods in their lives impacts on their own personal well-being, their communication skills, their interpersonal psychosocial interactions, their educational and vocational functioning. That if we think about it, it's that we are less interested, particularly as SOPs, in the structural or functional impairment of the auditory system. We are most interested in the factors that we can change, the factors that we can influence, the lifestyle, the frequent communication partners, the psychosocial factors. Again, and this idea of Jean-Pierre Gagne's AR model based on this international classification of functioning and a problem-solving approach. Where does AR take place? It takes place in lots of different settings, both medical and educational, by lots of different professionals. So it certainly is not confined to a particular setting or a particular professional. reimbursement through Medicare and Medicaid goes to SOPs to provide auditory training. The fitting of hearing aids and other electroacoustical devices, the diagnosis belongs to the audiologist and the physician, but there are lots of other people. And your discussion question for this week, due by next week, is to pick a population that you are particularly interested in, whether it's very young children, school-age children, working adults, or geriatrics, and to begin to think through some of these issues about what is the environment that that person lives in and operates in. You may want to look in the Nancy Time Murray text, Chapter 1, page 16, figure 1.7. It gives you a little thought about what are the different environments that people with different kinds of hearing losses at different stages in their lives may actually be engaged in. So take a look at that. Pick the population that you're most interested in. You may be, again, interested in different populations. Pick the population that you like the best and try to work through this series of questions. Who are the partners? What are the environments that this individual is likely to be involved in? But when we think about service delivery models in AR, there's sort of two big models. One is the medical model. It is a model that is generally considered top-down, authoritarian, where the clinician determines the diagnosis and the treatment. The clinician, meaning us, does something to the client under the assumption that the clinician knows what's right and what's best, that we have lots of degrees, letters behind our names, certifications, and that we know best. It's oriented toward disease and pathology, and it certainly is an appropriate model in an acute emergency medical setting, of course. But when we think about this idea of people with hearing loss, we really may want to see if we can switch our focus to this rehabilitation model. And again, I've put up some references for you to go look at. The rehabilitation model looks at a much more horizontal rather than authoritarian top-down communication approach. It's interactive, it's facilitated. The clinician helps the client identify and resolve problems. It assumes that the client's perceptions and needs will decide what the treatment regime should be. It assumes that the parent's perceptions and needs and desires will decide what the treatment/educational approach will be. So it's oriented toward helping the client self-actualize, adjust. It's this idea of well-being, living well with hearing loss. One of the things that we know is that if we look at the research on cost effectiveness and cost benefits, and we look at evidence-based practice, which Nancy Time Murray kind of reviews at the end of Chapter 1 on pages 17, 18, and 19 and 20. if we look at what kind of intervention can be provided to persons with hearing loss that justifies reimbursement for services through Medicare, Medicaid, third-party insurance, or private pay, we have to be thinking about what is the ultimate outcome that we want. And when we think about the ultimate treatment outcome that we want the person to be satisfied with the services they got. We want them to use the technology that is recommended for them. We want them to implement the communication strategies that they were taught in therapy. And what we're seeing is that we have tremendous advances in technology. Literally every year there are exciting new improvements in the devices that we are able to provide for patients. We have programmable hearing aids. We have cochlear implants with very sophisticated mapping. We have web-based learning. We're using a lot of computer-aided speech reading. I'll show you some software, almost avatars that help in speech reading, one called iBaldy. We'll look at this Clear training software by Nancy Ty Murray and Lace. So we have a lot of exciting new approaches. But when we think about what do we do in therapy with people with hearing loss, we always have to go back to looking first at what is their hearing loss. What are the basic, what is the degree of hearing loss? What's their configuration of hearing loss? How stable is the hearing loss? When did the hearing loss first present itself? Was it prelingual? Was it in the period of learning language called perilingual? Was it postlingual? Did this individual have oral language learned through the auditory modality and then lose their hearing? Has it been progressive or has it been sudden? When we think about who's on this interprofessional practice team, the core members always include the audiologist, the family physician, the otologist, the specialist in hearing health care, and the speech-language pathologist. So those are considered sort of the core interprofessional practice team. But there are always lots of others, again, depending on the age of the client and the setting that the client is in. So they're deaf educators, they're mental health counselors, they're psychologists, they're regular education teachers, special education teachers, interpreters for the deaf. There are both manual interpreters who use ASL, and there are what we call oral interpreters, individuals who simply repeat the oral information at a slightly slower and delayed rate. They're sensory device manufacturers and distributors. So there are individuals who are providing these various kinds of hearing assistive technologies. They're social workers. They're telecommunication and caption service providers. They're vocational rehabilitation counselors. We're going to talk a little bit about that. Those are the counselors who help adults or help high school age individuals with special needs who are transitioning to the adult world of further education or the world of work. So they are often on our teams. And the most significant other participant on the IPP team is the family. Hearing healthcare requires that families of both pediatric and adult clients be involved. Obviously, in terms of legalities, the IEP, the IFSP process requires legally that families and professionals share together information and develop a plan. But it's also true that for adult clients, families and other partners are team members. When we look at the effects of hearing loss on the adult client, there are social implications, there are vocational implications. There is a lot of research literature, and I gave you at least some of the basic references, looking at the effects that hearing loss has on the communication partner. This is a family disease, if you will. It's a disability that has significant implications for other people in the family. And so we need to be thinking about the family as a member of this team. They actually are a target of intervention. And some of you are going, well, that can't be. We're working with the client who has the problem, and we hope that families help and support. But in AR, the family, the partner, may actually be a target of intervention, not just help and support and bring the person to therapy and follow up at home. It's the partner may need to make specific changes in their behavior to facilitate the communication with their family member who has the hearing loss. So their goals and targets and strategies for the family member. And that's a very legitimate, well-researched, well-documented part of the rehabilitation plan. Because when we think about it, if we believe ASHA is right, that the components of an ecological approach, a rehabilitation model, if we just look at how communication happens, there's always a sender and a message and a receiver, and they're operating in some type of environment. And each one of those elements, the sender, which is the speaker, the parent, the teacher, the spouse, the healthcare provider, there's a message that's complex or not complex, that's clear or not clear, that's visual or auditory and visual. And there's a receiver, our patient who may have assistive technology or not, who may have strong language skills or not. And there's an environment in which this communication takes place. Is it noisy? Is it well controlled? Are they close together? Can they see each other? So those all affect whether the communication is, quote, successful. And each one of those elements can be a target of intervention. So when we think about clients with hearing loss, it is literally from birth to death. And what I want you to do in the discussion question is you pick which population seems interesting to you. Maybe none of them, but just pick one. Maybe all of them, but just pick one for right now. And then I want you to think about what kinds of partners and environments that person experiences in the course of a week. Is it home? Is it school? Is it some sort of social, extracurricular activity? Is it a vocational workspace? Is it in a community? Is it in a long-term care facility, a skilled nursing facility, or a long-term care facility? Think about the partners that your client population has. Family members, educators, neighbors, co-workers, merchants, service providers, healthcare professionals. And think about their communication needs. What are they trying to communicate? One of the things that people with hearing loss often tell us is that the difficulty of effectively communicating has significant impact on their social intimacy. That communicating is so hard, it's so fraught with difficulty and miscommunication and communication breakdown, that it's easier not to communicate at all, to isolate, to withdraw, or to deal with oral communication only at the most superficial level, to not really have a serious, intimate, deep conversation because it's just too hard. So we need to be thinking about that. We need to recognize that that is a frequent problem that people with hearing loss bring up when asked about their hearing loss and its impact. So we need to be thinking about, do they just need to communicate for educational purposes, for vocational purposes, for recreational purposes? What about religious and spiritual, their religious and spiritual lives? We've seen historically in this country that faith communities of all types have been very prominent in providing assistance to members and potential members of their faith communities so that you get technology, you get sign language interpreters, you get oral interpreters as a part of the religious faith community experience. So when we think about the components of an oral rehabilitation program, it's a joint responsibility of the SOP and the audiologist. It's not either or. That if you look on page 7 in your textbook, you'll see just a list of the components of an AR program. And not every AR program includes all of these. But these are the kinds of things that we want to be thinking about. We want to include at least for initial consideration. We may discard some. We're going to emphasize others. But we always need to do a detailed communication history and a detailed communication assessment, not just the audiogram. It's certainly true that the role of the audiologist is to provide us with audiometric data and to provide the patient with recommendations about amplification and to do the dispensing of the amplification devices. Sometimes if it's a cochlear implant or a BAHA that requires a surgical intervention, the otologist is also going to be involved in that surgeries. But then the audiologist will do orientation. But there's also part of assessment that is not just about the audiogram and a device. It's about auditory skills assessment, communication strategies assessment. And that's the role of the SLP. Audiologists typically do not do that. They move on to the next patient who needs to have amplification fit. The extensive auditory skills assessment and training, communication strategies assessment and training becomes the role of the SLP. So we do have a role in that richer, deeper assessment. Both the SLP and the audiologist provide informational, educational counseling. We're all pretty good at that. We like to talk a lot. But we also, in dealing with these patients, and we will talk about this extensively in Chapter 10 in our textbook, we do what's called rational acceptance counseling and psychosocial adjustment counseling. Now, we'll talk again about this later in the course, but that does not mean that we are crossing a professional boundary to do, quote, counseling, unless we also have a license as a professional counselor. But when the issue is hearing and hearing loss and adjusting to hearing loss, then that is in our scope of practice. And I think oftentimes beginning clinicians are so afraid of transgressing a professional boundary that they say, I don't counsel. I don't do counseling. I send them to somebody else. But my experience is that there are very few licensed professional counselors who've had much experience with hearing loss. So if the nature of the problem is about the hearing loss, and how do you adjust to that, and how do you cope with that, and that's what's hard for this person to accept, hard for them to see themselves as a person with a hearing loss, then oftentimes a general counselor is not going to have much to offer. It's actually the audiologist or the speech pathologist who spent much of their professional career helping people with hearing loss accept their hearing loss, adjust to their hearing loss. So when we talk about counseling, we're all good at telling them. We can do informational, educational counseling. Here's what your hearing loss means. Here's what you need to do. We're good at giving advice. This other part of counseling, helping the patient accept the loss, adjust to their hearing loss, adjust to the kinds of typical problems that hearing loss presents, may well be within the scope of the SLP and the audiologist. Another component of our rehabilitation training is this idea of frequent communication partner training. Again, we're looking at some of these components on page 7, table 1.1 in your text. We do speech reading training. We do speech and language therapy. We may do in-service training for other professionals, obviously, teachers in public schools, but also caregivers, certified nurse technicians in our skilled nursing care. We also frequently facilitate peer support groups where parents of children with hearing loss get together, spouses of individuals who have received a cochlear implant as an adult, adult children of geriatrics. So when we do this communication skills assessment, our role as SOPs is to assess these things. This is not typically the audiologist role. You notice this is the SOP's role. So we're going to do a detailed communication skills assessment. We're going to learn about the person's auditory functioning, their speech reading ability. We will do a cursory speech assessment, and in many cases, we will do a much more detailed speech assessment if that's called for. We'll look at their language skills, including their conversational discourse skills in particular. We'll look at any use of a signing system, American Sign Language, or any of the manually coded English systems like C. We'll do self-assessment of social functioning. There are many excellent, and we will look at them, and they are in your textbook and in the additional materials that I'll provide you. There are many self-assessment tools where patients rate themselves on Likert type scales, typically, of what their social functioning is in different environments. The audiologist role is different from the speech-language pathologist role. So they are clearly doing diagnostic assessment of the hearing impairment. They select amplification. They dispense the amplification systems. They do initial hearing aid orientation and training, initial cochlear implant or BAHA training. They discuss with patients what are possible hearing assistive technologies, captioning systems, device interfaces, text telephones, video chat technologies. But the truth is that an audiologist does that in a one, maybe two orientation to the device sessions. Many of our patients need much more. If they are to successfully manage their devices at home, at school, at work, in the long-term care setting, they need repetition. They need modeling. They need practicing under the eye of someone who knows how to do this. They literally need to practice putting the battery in the device. They need to practice inserting the device, putting the device on. So it oftentimes falls to the SLPs to provide that practicing and that ongoing monitoring. So again, the SLP is going to have a role in amplification, primarily in monitoring and training the patient to actually use the device, setting up a program of gradual increasing percentage of time that the device is used. The SLP obviously does communication. They do speech reading and auditory training and communication strategies training and conversational skills training and sign communication if that is the choice of the individual or the individual's family. And then they do counseling. We're going to talk in this class a good bit about a model developed by two audiologists who focus on rehabilitation audiology, Shao and Mirban. And they call this model the core and care oral rehabilitation model. The reason I like to introduce that in this class is I think as SOPs, oftentimes we have a low percentage of our caseload devoted to people with hearing loss. Now, that's not always true. Someone might decide to be the SLP in a school for the hearing impaired, or they might focus exclusively in an early intervention program for hearing impaired children. I certainly did that in my career. But for the most part, most of us, as general SLPs, do a lot of different things. We are generalists. And hearing impairment comes along every once in a while. And so our skills tend to need refreshing. We tend to go, okay, what is my go-to? This is a person with a hearing loss. What am I supposed to assess? This is a person with a hearing loss. What is my treatment plan supposed to look like? And this is what I call, quick and dirty. This is an acronym, CORE and CARE, to help you as an SLP go, did I touch all of these points? In my assessment, and we're going to go over them, did I touch everything in CORE? In my treatment plan, did I touch everything in CARE? So the CORE part of the model focuses on assessment. As patients come into the process, it focuses on the diagnostic and identification process with 4 components, C, O, R, E. CARE focuses on this ecological model of managing the patient, writing the treatment plan, focusing on the patient-client needs in 4 critical areas, again, consistent with the World Health Organization model of disability, where we're looking at the impact of the biological impairment on the individual's participation in societal context or activities, eating, sleeping, drinking, going to work, and environmental factors. What are the settings? What are the supports that that person has? What are the barriers that that person encounters in the environment? So here's CORE and CARE. I urge you, as you write your case study, to consider CORE and CARE. That doesn't mean you have to do all of each of them, but you need to consider, would this be a component that I might want to include? So the assessment of CORE says, I'm going to assess my patient's communication status from the perspective of what is the impairment and what are the activity limitations that it imposes. Auditory, visual, language, manual systems, communication self-report, previous therapy, previous rehabilitation. So what is this person like as a communicator? That's fine, Amber. I find that oftentimes over the summer people are mobile and then they go home and then they're on the computer. That's fine. Remember, I always archive or record everything. So if your mobile device goes out, your computer loses all the juice it had, you can pick it up. In the CORE model, the O of CORE stands for overall participation variables. Meaning when you look at that patient, you don't just look at that patient as ears and mouths. You think about them from a psychological perspective, a social perspective, a vocational perspective, an educational perspective. So you ask those questions and try to get that information, whether it is from a parent, a teacher, a spouse, a healthcare professional in a long-term care facility. You're trying to get more information about that person's overall participation and where does the hearing loss impact them. The R in CORE is related personal factors. The obvious easy ones are gender, race, age, cognition or IQ and personality. That A, that very first one, attitude type, was added by Schau and Nirenberg because in their experience, some patients are ready for therapy and some aren't. And that's particularly true in hearing loss, especially as the client becomes an individual, whether it's children who decide, I've had enough, I don't want to come back anymore, to adults who say, I don't have a problem, you mumble, to adults who are coping with the severe effects of dementia or aphasias or other life-threatening kinds of issues. So we can divide patients, and we will do this in consultation oftentimes with medical professionals, particularly if it's an adult. Is this person non-compliant? You'll hear that term a lot in your medical settings. They won't cooperate. They won't take their medicine. They won't put on their hearing aids. They won't engage in therapy. So all the way to the patient is can't wait, wants to come, is anxious to resolve their problems. So that is an important consideration, and we would be less than honest or candid if we fail to recognize that the patient's attitude as part of these related personal factors does influence our plan. The last element in CORE, C-O-R-E, is environmental factors. That's where we look at our patients and we talk about what services are actually out there for them. What systems can support them? Is this a person that can get help from vocational rehabilitation? Is this a person that can get help from special education, IDEA, through an IEP or an IFSP? What barriers are there? Is this a person who works in a large corporation who fully understands their responsibility under the Vocational Rehabilitation Act and the Americans with Disabilities Act, that they must accommodate workers? Who are the facilitators that can help this person? What are the acoustic conditions that this person lives and works and recreates in? Is it loud? Is it noisy? Is there glare? What are the visual supports that are there? One of the unfortunate things that we'll spend a lot of time talking about is that schools are terrible acoustic environments. They are highly reverberant. They have lots of ambient noise. They have lots of internal noise. You could hardly think of an environment that is more acoustically hostile than the typical school classroom. There are new guidelines that apply to new school construction, but the vast majority of school buildings in this country were grandfathered in when there were not standards in place about acoustic characteristics of classrooms. The other terrible acoustic environment are skilled nursing facilities. They are highly reverberant, hard surfaces that are easy to clean, lots of bright lights, but that produce terrible problems for individuals with macular degeneration, glaucoma, and cataracts, so that these people who desperately need visual speech reading clues to supplement their weaker auditory skills are kind of, it's the double whammy. It's loud, there are machines going, The walls, sounds are bouncing off of them, and there's this glare coming in, these wonderful windows that somebody thought would be great, and they are bright and cheerful. But I can't see anything because of the glare. So that's just sort of one of the things that we need to be thinking about when we do an assessment. So there are all those things, and any of those elements may be a target of our intervention. Cheryl and Nirvan then say, here's another handy-dandy little mnemonic device for how to write a treatment plan, how to manage a person with a hearing loss. CARE, how to write a care plan. Counseling and psychosocial. Again, maybe that's modifying this attitude. Maybe that's helping the patient get to a point where they can admit that they have a hearing loss, admit that it is producing difficulty for them or for their communication partners. It may involve simply interpretation of the audiogram, giving them information, but it also may involve this counseling and guidance about acceptance of the hearing loss, understanding of the hearing loss, setting realistic goals and expectations. A in CARE stands for audibility. We are, as SLPs, going to try to support this client in gaining the best access to the acoustic speech signal that we can possibly provide. In concert with audiologists, we're going to provide hearing aids, cochlear implants, bone-anchored hearing aids, various other assistive devices. And we are going to be providing instruction and orientation to those devices repeatedly until our clients can accomplish the management of their devices. Again, it's not that the audiologist didn't do his or her job. That audiologist, in all probability, did an excellent job of fitting a device, explaining the device, showing the patient how to manage the device, how to insert the batteries, how to put the hearing aid or the bone-anchored hearing aid or the cochlear implant on. But people don't learn it the first time through. It's a strange and different world for them. So they need lots of repetition, lots of coaching. So think about it as coaching, modeling that you're doing. The R in CARE is remediate the communication activity. So this is where you look at where is the breakdown and you teach remediation strategies. So you teach tactics to control the situation. Move closer, turn the TV down, reduce the noise, look at the face of your partner. We work on helping the patient build a reasonable expectation. We then work on personal skill building. So we teach auditory training. We teach lip reading or speech reading. We teach communication strategies. What do you do if at first the patient doesn't understand? You teach the partner. The E in the CARE plan of management by Cheryl and Nirvan is back to environment. So the E in both of these, CORE and CARE, is environment. It's about looking at how we can coordinate, how we can make the person knowledgeable about what their rights are. Do they understand the laws that actually can benefit them? Do they know what their legal rights are? Does their communication partner know how to be an effective partner? In their community, what are the resources that they can use? What are the recreational and social activities that are accessible? So when we think about managing hearing loss, writing treatment plans for people with hearing loss, we have to realize that fundamentally it is about coordination of services. Services to these individuals oftentimes are provided in multiple settings. There is more than one provider. There's an audiologist, there's a teacher, there's an SOP, there's a OT, there's a PT, there's a respiratory therapist, there's a nurse. There are multiple providers in often multiple settings. And of course, it's ideal if everyone collaborates, that interprofessional practice is implemented at a high level, but sometimes it's not. We have to recognize that part of our role with SOP is to not only always include the family and other partners in the rehabilitative effort, but to go that extra step, to contact the other professional members of the team. So to work closely with the teacher, to work closely with the CNAs, to train and provide guidance to those other professional partners and non-professional partners. So that sort of is this overview of how AR looks a little different than the other courses you've had at TSU about one of the big 9 disorders. It is a much more holistic approach. It is oftentimes short-term, particularly when we're dealing with adults. It's not forever and ever, because our goal is to help the patient gain enough skills and enough insight into their problem that they can problem solve for themselves in a new situation. So we send our kids off to college, and many of our hearing impaired kids, helping them choose a college that does have a rich array of supports, disability supports, putting them in touch with a vocational rehabilitation counselor who can provide services, both technology services, but also assistance as they negotiate the new world of college, for example. So again, our role may look a little different than just doing traditional therapy. I want to call your attention to your textbook at the end of the chapter. Nancy Ty Murray provides you with the ASHA document on the knowledge and skills needed by SOPs. She provides one for audiologists too. But we're going to focus on what are the knowledge and skills that SOPs need to provide AR training. So this is the ASHA document that says, what do you need to know? It's on page 131 in the text, and it talks about basic areas of knowledge and skills. And it talks about general knowledge, talks about specialized knowledge, about auditory systems, developmental cognitive status, cognition, talks about auditory assessment, communication performance assessment, devices and technology, talks about the effects of hearing loss on psychosocial, educational, and vocational functioning, talks about intervention and case management, talks about interdisciplinary collaboration and public advocacy. It talks about acoustic environments. I want you to take a look at that. It's page 31 through a couple of pages, through 35. And I want you to just read down that. Those actually are all topics in this course. They're topics in this book. So you are, as diligent learners, going to come away from this course with the basic knowledge and skills that you need to provide services to this population. But you'll notice that your role does expand beyond, I just do speech therapy. It's about advocating. It's about knowledge about acoustic environment. It's about knowledge about devices. It's about looking at patients holistically. So we want to be thinking about, that's what ASHA says to us, that this is an ecological, interactive, facilitative process, that it's about IPP and collaboration, and it's about a whole lot more than just traditional therapy. Everybody need just a moment. Can you hang in there? I think this is the hard part of this summer class. We still have a little, we are not going to go for a whole another hour and a half, but we still have an hour and a half left of class time. But let's take a little break again. Go get something to drink, take a little break, and we're going to come back and talk about characteristics and consequences of hearing loss. There's psychosocial, educational, and vocational impacts. So we'll do what ASHA tells us to do. And this actually, we're going to take it from the perspective mostly of Chapter 15. So, and I'll be happy to answer any questions. Okay, is everyone ready to see so we can have a last go at this last little section from Chapter 15, where we're going to talk a little bit about characteristics and consequences of hearing losses. But let me stop and see, are there any questions that I can answer that came up for you while we were on break or from that last little section? Everybody okay to keep going, or have I lost you all? You with us? Okay. Holding on. It's a long night. Again, remember, I have archived this, and you can go back and listen to it if you need to. The reason I want to talk about this chapter 15, at least a quick run through, is I think it does help us look at the different types of approaches that are used with children with hearing loss in terms of different modalities. And we are going to talk a little bit about the vocational rehabilitation counselor. We will come back at the end of this course and deal in much more depth about speech training for children with hearing loss. We'll be looking at children with mild and moderate hearing losses. So we'll spend a good bit of time talking about more details. We want to focus tonight on the team-based process and how when we work with children with hearing losses, we're looking at broader consequences. One of the things I do want to point out in this chapter, if you will look on page 652 through 653, there's a table that I think will be extremely helpful to you. It's table 15-16. It is a table that has been reproduced lots and lots of times in lots and lots of books. It was developed originally by some audiologists, Noel Mackin and Carol Anderson, to try to help essentially teachers get a handle on what do different levels of hearing loss actually mean in terms of educational needs and programs and psychosocial consequences. I know Dr. Matlock did a wonderful job of teaching you about degree of hearing loss and minimal, mild, moderate to severe, severe, profound, and unilateral hearing losses. And that's important to know because you will be the person as the SOP on the IEP team or the ISSP team for most school-age children when trying to explain to other non-audiologists, non-SOPs, non-teachers of the deaf, what does this mean? What should we expect from this child? What are the consequences of a hearing loss of this degree on the child's psychosocial development? What is anticipated to be the child's educational needs? What kinds of programming should we be thinking about? That being said, some of you are going to say, but every child is an individual. Absolutely. Some children have severe hearing losses and they actually function like children with moderate hearing losses. They are excellent users of amplification. They were identified early. They have highly committed, well-educated, well-resourced families. But that is not the norm, perhaps. So when we think about trying to help educators develop programs for children, these rough guidelines, where there are certainly exceptions, but these rough guidelines give us a way to start the conversation, to say, for a youngster with this degree of hearing loss, we should at least be aware that the research evidence would suggest that some of them may have these possible psychological, psychosocial characteristics. These children typically need this type of educational programming. Again, there are always exceptions. That's why we have IEPs and IFSPs that are individualized. But because hearing loss is a hidden handicap, it's not visible, and because most educators don't have extensive experience with children with hearing loss, some of these sort of generic guidelines become important. And our role as an SLP oftentimes is to be a leader in that interprofessional practice team to provide just basic foundational information. This table, again, is available in lots of different textbooks, in lots of different forms, on lots of different websites. But I urge you to take a look at it because I think it can be useful in in-service training. It's useful in individual counseling. When we think about the prevalence and incidence of hearing loss, it's widely varying. We know that as our population ages, as individuals age, there is an increased incidence of hearing loss as we move through the decades of life. Typically, when we talk about school-age children and youth, approximately 5% of them have some degree of hearing loss. We just talked earlier this evening about the fact that although the statistics here would say that 43% of individuals in this country of 65 and over have a hearing loss, you heard me quote a statistic that said 80% of residents in skilled nursing facilities have a hearing loss. And that difference really represents, the skilled nursing facility may represent sort of that, often that next decade of life, and it represents individuals who are compromised in some other way. They have another health condition that sent them to the skilled nursing facility. So again, you have to be cautious when you look at these prevalence and incidence figures. But what we know from a lot of research is that an individual with a hearing loss, if you just look at the average of what happens, there is an effect on family income, employment status, educational attainment, believe it or not, even marital status. Now, that does not say that hearing loss caused low income or caused unemployment and underemployment or caused limited higher education opportunities or caused marital dissolution. But it says it's associated with it. So when we see these problems arising in our clients, we shouldn't be surprised. We shouldn't go, well, what does that mean? It means that this has happened in the past, unfortunately, and that it might be a consequence or an outcome. Because hearing loss became such a significant problem following World War II among young veterans returning from the war. This country, not immediately after World War II, but in the decades following World War II, began to become concerned about rehabilitating typically young men and young women returning from the service from World War II, returning from Korea and returning from Vietnam with substantial disabilities, including hearing loss. And so in 1973, the Rehabilitation Act of 1973 began to provide a system in this country to offer vocational rehabilitation, including a whole array of services that were put in place to help individuals with hearing impairments obtain good jobs, to improve the quality of their work environments, and to help those individuals move successfully into the civilian labor market. That was really the purpose of vocational rehabilitation. That actually has been a good thing across the board for people with hearing loss, because it alerted employers to the fact that these individuals with appropriate accommodations and modifications could hold a job. It also provided for adults to receive hearing aids and other assistive technologies, speech therapy, speech reading, language training, auditory training, American Sign Language training. So this process was set up free of charge to the individual to help an individual, both students exiting high school and individuals returning from the military service, individuals who experienced some sort of sudden or traumatic accident, to provide them with a way to enter into the workforce again. So here's sort of the steps that go on in a vocational rehabilitation process. What we need to know, the important piece for us as SLPs, is to know there is someone out there who can do this. This is a service that my client could access. There is this person called the vocational rehabilitation counselor, who is much more skilled than we are at this personal and career counseling, developing an array of services and training, managing and coordinating a vocational rehabilitation plan, advocating for these clients with employers, and literally helping them seek an appropriate job with appropriate income. So the vocational rehabilitation counselor is the person who can do this comprehensive assessment or fund it. So many SLPs working in various community agencies have the client's fees paid by vocational rehabilitation. And vocational rehabilitation covers sort of the waterfront: amplification, job skills training, psychological counseling, career counseling. For those people with congenital hearing losses or long-standing hearing losses from childhood, the vocational rehabilitation often is the source of support for students in any kind of post-secondary education. So when the student exits the IDEA special education process in order to get support services at college or vocational technical school, it's Section 504 of the Vocational Rehabilitation Act that actually provides those support services. So provides interpreters, provides translators, provides technology devices. And those of you who work with high school students in IDEA in a secondary school know that you have to develop a transition plan for those students as they exit the IDEA secondary system. And this is a person, the vocational rehabilitation counselor, that you do want to access, help your student know that, help their families know that. Vocational rehabilitation actually also assists clients with multiple needs. And if we look at the most recent data, 40% of school-age children with hearing loss have another disabling condition, another IDEA condition. So they are multiply handicapped, not necessarily multiply handicapped in the IDEA sense of that, but they have another disability. So frequently those are clients who have needs for can they live independently? Do they need supported group home kinds of living arrangements? Do they need supported employment or transitional employment? And again, that's where vocational rehabilitation can address some of those needs. So they are sort of another person that you would put on the team if you are dealing with that young adult population. So speech pathologists and audiologists frequently do collaborate with vocational rehabilitation counselors to try to assist their clients with therapy needs, amplification needs, these support services like oral and manual interpreters, career planning, job training. So VR not only provides simply the money, the financial resources, but they provide this valuable counseling support for individuals. So they are another person on the team. If we look at educational rehabilitation processes for children with hearing loss from Chapter 15 in your Nancy Ty Murray text, School-Age Children Who Have Hearing Loss, ASHA reminds us that there are 4 major ways that a hearing loss affects children. It causes a delay in the development of receptive and expressive communication skills, speech and language. We all get that. That's what we do. We recognize that. But it's the downstream consequences of that hearing loss. The hearing loss and the language deficit that results frequently does cause learning problems in the group learning setting, and that results in reduced academic achievement. So these children with hearing loss traditionally have academic skills that are not age and grade appropriate. There are exceptions, but the general data continues to show that because of the language deficit and the resulting difficulty in learning, these children have reduced academic achievement. In addition, their communication difficulties, according to ASHA, often lead to social isolation and poor self-concept. Again, somebody's going to say, but I know a child with a hearing loss who's the president of the class, who is outgoing, and that's absolutely true. Everyone is an individual. But if you look at data sets of large numbers of children with hearing loss, you do see an increased risk for social isolation and poor self-concept. And that then spins off to have an impact on vocational choices. So these youngsters tend to choose areas of study or potential jobs that don't require sophisticated communication skills. And even beyond that, they are hesitant to attempt new and different kinds of experiences. So we see language skills, learning skills, communication skills, social isolation and self-concept, and that impacting their vocational choices. So when we talk about educational management and AR for children with hearing loss, again, we're talking about a big set of issues that have to be addressed, far beyond just speech and language. So educational management is clearly a collaborative IPP team-based effort. Obviously, all of the laws that we studied in the spring in schools, Public Law 94-142 and its successor laws, IDEA 2004, Part C for infants and toddlers and B for school-age children, apply to this population as well. Hearing loss, hearing impairment, and deafness are IDEA eligibility categories, so these children are clearly eligible for all of the supports of the special education system. The team members in a school typically at a minimum include teachers, administrators, parents, audiologists, and SLPs. Again, the role of the SLP in a school-based team is not only to provide speech and language therapy, which is obviously the primary role of the speech and language pathologist, but to help monitor amplification devices. That does not mean that the SLP monitors every child's hearing aid, cochlear implant, Baha, FM system in the whole school. But they must talk with administrators and other special education coordinators to make sure it is done on a daily basis because it's mandated in the law. So school systems have to set up a daily monitoring program for amplification devices for children in schools. SLPs oftentimes are part of that training, but they're certainly part of the team that designs the program, makes sure it's in place, makes sure it's implemented. It can be implemented by a trained paraprofessional or some other tech professional, or by a teacher, or by a parapro. But the process must be in place. The SLP clearly is there to support the family's right to choose the educational approach they prefer. We have to always remember our ASHA ethical guidance and our ASHA scope of practice. Our role, according to ASHA, is to support the family in their choice of communication modalities. This is probably the one area where it's not whatever the school professionals want is supported. Because of this interplay between language and culture, families who choose a manual approach for their children are making a choice for their child to be part of a deaf community. And that's a cultural choice as well as having educational implications. So it's not that the teacher and the principal and the SOP and the audiologists get to decide. This is one of the places where the rubber meets the road, and the family has a right to choose the approach that they prefer. The SOP is there. There are a variety of ways that amplification can be provided. If, in fact, Jill, all other options have been exhausted. Medicaid pays for hearing aids and cochlear implants. So it's rare that a school district ends up paying for medical devices. If a district believes that a child needs an FM system and they're going to use that FM in the classroom to enhance the child's access to the curriculum, yes, they can provide that. Yes, that's correct, Nicole. That's absolutely correct. That most states, in fact it's most states, have mandates that hearing aids are covered under children's medical insurance. So it's rare that a school is ever really in that position. Now they have to help the family access that. And it's really the classroom amplification system. So if the audiologist says, I think a classroom sound system, amplification system, is an appropriate thing for this youngster and all the other youngsters in the classroom, then that becomes educational technology as opposed to an individual hearing aid. And there is a specific exception in IDA 2004 that schools will not be required to pay for medical surgical interventions. So schools specifically in the law were not required to pay for cochlear implant surgery or BAHA surgery. But that's covered under medical insurance. So it's not the child doesn't get it, it's just that you don't use education dollars. What SOPs do in schools is that we advocate for appropriate accommodations and modifications. So again, that may mean actually going into a classroom, modeling, coaching, assisting teachers with how do you provide appropriate modifications and accommodations for children with a hearing loss. How do you provide compensatory strategies? And again, particularly if you are in a school system where there are few children with hearing loss, and the general education teacher has not had a lot of experience with hearing loss, that may mean a significant demand on the SLP as they serve in that consultative role. So the role of the SLP may well be the case manager. The SLP is the resident expert in hearing impairment. There's not an audiologist in that building. I'll just almost guarantee you that. The audiologist is not there every day to answer all the questions. The SLP is seen as the resident expert, the resource. They're certainly a service provider. They're certainly going to be implementing individual and group intervention that meets the unique and encompassing needs of different students with hearing impairment. But they're also this interprofessional practice team member where they are helping interpret assessments in light of the hearing impairment, adding insight into this typical performance patterns of children with equivalent hearing losses in similar settings. That's why this table 15-6 on page 652 and 653 is really a help for you in that trying to interpret a particular child's assessment results in light of what other children with equivalent hearing losses do. And they're facilitating the synthesis of information into a cohesive whole. So what you've got is the audiologist says something, the school psychologist says something, the classroom teacher says something, the SLP presents speech and language assessment data. Somebody has to pull that all together, and it typically falls to the SLP. It also falls to the SLP often to educate the school system and sometimes the family about the various communication modalities for deaf and hearing impaired children. And so we as SLPs need to be at least minimally knowledgeable about each of these communication modalities. And that's why in your communication modalities project, you want to be having a section on these different modalities. So the oral approach, where we focus on teaching children speech and language skills primarily through the auditory oral mode. Auditory verbal therapy is a specific approach that emphasizes audition first, working with children to maximize their use of audition as the primary mode for developing speech and language skills. Cued speech, a supplement to speech reading designed originally by Dr. Cornett in the mid-1900s, 1965, I think, to help individuals decipher information that is neither visible on the lips or auditorily accessible. So it adds extra handshake cues. It's not a language, it's a supplemental support. American Sign Language is the language of the D, capital D, deaf community. It is a whole separate language. It has a different structure than English, and it is the preferred language of the deaf community. There are other signed systems, some of them known as manually coded English, which uses sign language vocabulary in English word order. So it's a made-up system developed originally by deaf educators who were so concerned that deaf children who used American Sign Language continued to be poor readers of English. And so they said, we need a system to help these children learn English language, English word order. And so they attempted to manually code English. So these systems are English with signs to accompany it. We're going to talk more about those. Total communication systems, sometimes called simultaneous communication systems, where the individual is learning through all methods, auditory, oral, sign, oftentimes using finger spelling, where literally the English words, in this case, are signed letter by letter. Something called bilingual bicultural, meaning we recognize that for deaf children of deaf parents who grow up in a household where ASL is the first language, that we want those children to develop a rich and full ASL language system to communicate with their family members. But we should then view their learning of oral English just as we would view a Spanish child coming into the English mainstream school setting as a bilingual, a bicultural situation. So the analogy is made that ASL to oral English is a bilingual and bicultural transition. And that many of the techniques that have been effective for other bilinguals might be effective in making that switch. So I just put a very brief definition of what each one of these things are. We're going to talk more about them, but in your communication modalities project, you want to make sure that you've covered each one of these different modalities as a possible approach for educating children with severe hearing loss. When we talk about those manually coded English systems, there are essentially 3 of them, although there are some other variations. One is called Seeing Essential English 1, Seeing Essential English 2, and one is called Signed English. They're all very similar. They're designed to represent English language following the word order and grammatical inflections of English. So it is English, but it simply uses ASL signs and sometimes the finger spelling to put an S on the end of a word, or finger spelling to put an ED on the end of a word, so that you're learning grammatical inflections using a signed and finger-spelled addition to put in articles. Because ASL doesn't have those same grammatical inflections. It has grammatical inflections, but they're coded differently by movement and posture and direction. When we think about the characteristics of children with hearing loss as this table that I referred to in your text, table 15.6 on 652 by Anderson and Matkin, it tries to help us look at the psychological effects and the communication effects of hearing loss by different degrees, and the social emotional effects. Again, one of the things in terms of social emotional effects that I think we all should be acutely aware of, and that the research literature is continuing to emphasize, particularly in the last 5 to 7 years. I know when I went to Italy last year to present on auditory processing to that international conference, there were lots and lots of research papers about this idea of how fatigued individuals with hearing loss become due to the strain of listening. And all the way from children to adults. And there are lots of different ways to measure that. There are lots of research protocol issues that are interesting for researchers. But the takeaway message, I think, is that perhaps we have discounted that, and that we really have discounted that, particularly in school-age children. We tend to say, oh, they're just fidgety. Oh, they're just overactive. Oh, they're just not paying attention. without actually understanding how, at a very real physiological level, straining to listen takes a huge toll on their cognitive resources as well as their auditory system. And so what may look like a behavioral problem, or daydreaming, or not paying attention, or being tired, may really come back to a consequence of the hearing loss. And I find that when I talk to school faculty, that idea is new for them. Not that they don't get it. In fact, they get it pretty quick when you bring it to their attention. But again, that's one of the places that I see our role as SLPs on these school-based teams being to have that knowledge, to try to share that with others, to help faculties see that some of these social emotional effects that we oftentimes see in children with hearing loss can be resolved, or they can at least be ameliorated if we recognize that this fatigue factor is real and we give them a different schedule. We provide more break time. We provide alternating heavy listening load activities with less heavy listening load. We recognize that oftentimes these kids do not have the pragmatic social communication skills that they need to effectively interact with their peers. So they need not just speech and language, but they need social pragmatic communication skills. Oftentimes we as speech pathologists are so elated when a child with a hearing loss can communicate effectively in reasonably intelligible, articulated speech with reasonable grammatical structures that we go, oh, we're done. Look how good he's doing. And we fail to realize that we didn't take that next step. We didn't really work systematically in a treatment plan on social, communicative, pragmatic skills. And the data is pretty impressive that even our stars, our cochlear implant children who were implanted early and provided with lots of early intervention, who were the perfect 10, that's the goal of the educational hearing detection and early intervention. We want all children to be identified with a hearing loss, to be diagnosed, to be fit with appropriate amplification and intervention. And so they are the perfect 10, 1, 3, and 6. By 1 month, they are screened. By 3 months, they're fully diagnosed. By 6 months, they're in an intervention program, and they become the perfect 10, the perfect 10 to be successful. But what we oftentimes, as SLPs, even those children who are the perfect 10s, the stars, the ones that we write up in our journals, the data that we have says that even those stars have pragmatic language difficulties. They have social communication interactive difficulties. And that maybe is what makes them have difficulty with making friends, particularly as adolescents. That's part of this resenting their hearing aids, their FMs, their CIs, becoming dependent on teacher assistance. So they're still adult focused rather than peer focused. So again, often our role exactly Jill, it's the same, it's exactly the same kind of thing about this autism stress, how exhausting it is to process language, how exhausting it is to listen in this acoustically hostile environment of the classroom that's noisy and reverberant, and that we don't realize the psychological strain that puts on these kids. There are clearly academic effects. This idea of lower educational achievement just is recurrent in all of the research data over decades. You know, and it's not about poor teaching, it's not about ineffective curricula, you know, one versus the other. It is of, unfortunately, persistent effect. The reading ability is significantly affected, poor written language and spelling. And so those poor language skills mean that they obviously have difficulty accessing the language and vocabulary and all the other subjects, science and math, as well as the traditional language arts. When we think about placement options for these kids, there are an amazing number of educational options. There are private schools for hearing impaired kids. There are public schools that are home schools. They're LEA. They're residential schools. These children are placed in full-time regular education classrooms with simply itinerant support from a teacher of the hearing impaired and a speech-language pathologist. They may be in regular education with some sort of substantial pull-out resource support. They may be in, you know, part-time, full-time. What happens oftentimes, particularly in smaller districts, is there are fewer of these children per grade, per school. So placing them in their home school, their LEA, is oftentimes difficult if they need this intensive intervention. So you do see, even in large systems, for example, the Metropolitan Davidson County School System is a big system, 85,000 kids. It's not the largest in the country, but it's a big system. And it has found that for children with severe and profound hearing loss, these children with the most significant educational impacts, that they do better to cluster them in a local school building, but that they can put more of them together and therefore get teachers and SOPs and an audiologist who visits often and a teacher of the deaf at each different grade level or 2 grades, so that they can do more differentiated instruction. And that's always one of the challenges, I think, of addressing the needs of hearing impaired children, particularly in smaller school districts. Can you provide enough resources for that child to actually meet their academic potential if there's only one of them in the school building? So it certainly is a challenge. When we think about the needs of these children, it's important to recognize that even with the best amplification, these kids simply have less access over their lifetime to normal language. That's why we press so hard for them to wear their amplification devices all the time. But we recognize that even doing that, they are missing out on that incidental learning. They don't learn new words easily. And oftentimes, they don't hear that word as many times as they're normally hearing peer. So they do have to be taught specific language in new learning situations. They need visual, concrete support for learning new words, for learning new concepts. They may have problems following directions, and particularly whole class discussions. So they're missing a lot of the input. Typically, these children throughout their academic careers need assistance with vocabulary. They simply can't absorb, with their limited accessibility, the number of new words that are taught each day, each week, each month in the typical educational curriculum. So it's always going to be an issue of where do they get that extra support. Some families are in a position to provide that support. They can read with them at home. They can go over the biology lesson for tomorrow. They can provide that extra support. But many, many of the youngsters we work with are not in families where the family is able to provide that extra support. So we have to figure out, where can they get that? It is oftentimes the SOP. Sometimes it is the teacher of the deaf. But for each child, the plan needs to have in place, where are we going to get the pre-teaching of the vocabulary, the re-teaching of the content that they need to be able to master the basic academic content. So SOPs have a significant role in educating parents and teachers about the effects of hearing loss on language and speech and psychosocial development. Clearly, each child is unique. Clearly, all these averages don't apply to every child. But there is a clear relationship between the degree of loss in this table by Anderson and Matkin that's in your text and the general educational needs, the psychosocial consequences, and the programming recommendations. So that's a place to start when we start thinking about how do we program for these kids. Okay, I am done. I am happy to talk more. Sarah asked a question about Melissa's experience with her daughter and what she has experienced in terms of help and support educationally. I will let Melissa answer that, and you may want to contact her privately to talk more about that. I think that my experience is that many parents feel like schools could do more for their child than they are doing. And many parents feel like they find that school systems in general don't understand their children well. And I guess my thought about that is, as an SOP in a school system, I feel like I bear some responsibility for that. You can't, as we all know, you can't change everybody. You can't change the law overnight. But I do think that, in general, SOPs maybe have not been as assertive or aggressive in advocating for hearing impaired children as they might be. I think the truth is that most of us know this stuff, or certainly all of us, by the time we finish a master's degree and have a course like this, we do know it. It may not be top of mind, but we do know these things, and there's research to back them up. I think sometimes we are having trouble as SLPs finding our voice in a team-based process to, again, effectively advocate for what these kids need. And I think many school systems tend not to see the uniqueness of what these deaf kids need. They're just one more special ed child who has lots of needs. Like lots of them have lots of needs. And I think the very unique needs, the specific needs that they have, oftentimes don't get addressed in schools. So I will let Melissa answer about her experiences, but I think that in general I would say that parents of children with hearing loss oftentimes feel that schools aren't really meeting their needs.
Can you hear me?
Look, something's the matter with my microphone. I'm not.
How about now? So my experience has been a lot of fighting. It seems like everything that we've asked for Delaney has been denied, and I have 3 ladies that are all attorneys. I will not go to an IEP meeting by myself anymore. She had someone that was an aide to her in kindergarten that signed, and we wanted to keep this lady, and she wanted to stay, but she wanted interpreter pay, and they refused to do that, and we fought and fought, even though we thought sign language was helping Delaney, and we wanted to use total communication. So it's been rough, but I think we're in a pretty good place right now, so we're better than we have been.
Other questions or comments? Okay, I'm going to bid everyone good night. We certainly have been at this a long time, but I think we've gotten a foundation, and next week we will move on to talk about chapters 2 and 3. Those of you who tuned in just for tonight, if you didn't do your questions, please go ahead and submit those. And remember, you have a discussion that's an individual discussion, and then you just reply to any 2 of your classmates. Have a good night.
Hey, Dr. Fitz, I have a question, if that's okay.
Okay, I'm having trouble hearing you. Can you type or email the question? Melissa, I honestly don't know how, technically, you do meet the requirements of the speech teacher job. You have a degree in the field. You'll have 100 hours. I actually cannot imagine someone saying, but you don't have the speech language teacher. It is who an HR department in a local district chooses to hire is actually an individual decision. I don't think the State Department of Education would turn them down and say, no, you can't hire this person because you have to hire someone with the SLT credential. So I certainly think it's an appropriate thing to apply for. What you need, what will happen is, I don't know that they can put you doing both. So if the school district has a position as an SLT, and you take that position, then I think you will be an SLT. I don't think you can be an SLT and then on Tuesday morning, when they need you to administer an assessment and sit in and be the evaluator of record, in an IEP. I don't think you can do that. So I think that's something that you and the director of special ed would have to have real clear. Are you simply moving into the role of an SLT, and that's where you want to be and are happy doing that? I tell you the other thing, if you are on the grant funding from Dr. Smith, I would ask her that question. Not about the job, but would an SLT position meet that obligation? Okay. Yeah, just check your loan. That's what I want to make sure about. Good luck. Let us know. Have a good evening, everyone. Good night.